congenital malformations and the different causes. And then we talk about the effects that teratogens have on prenatal development. And then we go into the topic proper, which is the principles of teratology. We'll try and look at classifications of teratogens, and then we'll talk about the role of the ultrasound, and then some discussion points. So as the name implies, teratology is actually derived from a Greek word, teras meaning monster, and teratogenesis means something that produces a monster, because in those days when you deliver a baby that looks abnormal, they call them monsters. And teratogenesis is actually the study of the mechanism that leads to the occurrence of congenital malformations. So teratology studies the causes, mechanisms, and patterns of abnormal development that occurs during pregnancy and eventually leads to congenital malformations, which are seen when the baby is born, sometimes picked up earlier during pregnancy as well. But teratology is looking at the subset of abnormal development that occurs because of an external influence on the developing fetus. That means external influence from the environment. That could be drugs, environmental pollutants, and other examples like that. This is the distinction from birth defects, which could have congenital or genetic causes in addition to teratogenic causes. Next slide, please. So a teratogen can be said to be any agent that can cause a permanent alteration in the fetus due to exposure of the mother. And that alteration can be in the structure of the fetus in terms of a structural anomaly, or in the function of one of the cells or organs or tissues of the fetus. That is a functional abnormality. And there are so many different agents that could act as teratogens. It can be alcohol, drugs like cocaine, even cigarette smoking. It can be maternal conditions like diabetes mellitus. It can be environmental pathogens, lead, mercury, and the likes. Next slide, please. So we'll move briefly to a little background. It's important to remind ourselves that all pregnant women are at risk of having a baby that has a congenital anomaly. It can occur in any woman. But generally speaking, it's said that 5% of all pregnancies actually do have congenital anomalies. And out of the number of women that have congenital abnormalities, about 10% of them are said to be caused by teratogens. Congenital malformations generally compromise the quality of life for millions of affected individuals. And it's not only the individuals. The child's life is compromised, the family's life is compromised, and it's also a big drain on health resources of both the family and the nation, because they need to put in so much to take care of these affected children. So it's important for us because teratogens can actually be avoided. At least some of them can be avoided. So it's important for us to learn about teratogens, how they cause defects, and how we can avoid exposing pregnant women to teratogens, thereby reducing the occurrence of these bad defects that are actually preventable. So a little of, next slide, please. A little of history. Let me see if I can, okay, let me see if I can try the slide sharing again. Something is coming up. Can I try, Dr. Enabuduso? Hello? He's muted. All right. So his historical timeline, well, it was in the 1930s that it was actually realized that the fetus was actually susceptible to being affected by congenital, by environmental conditions.
Sorry, Raji, do you still want to share the slide? The stress there will be because you know you are out of town. Yeah, because you're out of town, the network.
Sorry?
Because you're out of town, your network, you think it will be able to, you can share it?
I don't know, I just want to pop up now because I'm having some time lag between my, maybe I'm going too fast, between your movement of the slide and
okay.
my talk.
Let's give it, okay, give it a shot. Let's see. I'll stop sharing now, so you try yours, let's see.
Sorry, please, just a few minutes. Okay. Can you see the slide now?
Not yet.
Not yet. I'm really sorry about this, yes. It's hereditary, but sometimes you can have some genetic influences in expression of occurrences or exposure to teratogens. So classes of congenital malformations, of course, we know that we have major anomalies, we have minor anomalies. The major ones are less common, said to affect about 3% of live births, and they can affect the function or social acceptability of the individual. And they've also been said to be a leading cause of perinatal morbidity and mortality. For the minor anomalies, they don't have much consequence, but then it's important to know that once you have one anomaly, you could have several other hidden. So one needs to check properly. And by the time you have more than one minor anomaly, the chance of having a major defect actually increases, particularly when you have 3 or more minor anomalies. So birth defects can be caused by different causes. A lot of the time is actually unknown. And then, of course, we have the chromosomal or genetic causes, the teratogens, like we said, and then a multifactorial cause of birth defects in which you have an interplay between both the genes of the conceptors and the mother, and also the environmental exposure to teratogens. Now, this slide is showing us an illustration of the different causes of birth defects. And I'm not sure if you can see my pointer there. This slide here shows that environmental teratogens account for 7 to 10% of causes of birth defects. And you can see that the unknown etiology actually forms a major bulk of birth defects. But then this 7 to 10% may seem small, but it's actually very significant because this can actually be preventable. They are potentially preventable causes of birth defects. So it's important for us to investigate teratogens and know how to avoid exposure of our pregnant women to teratogens. Yes, statistics, well, we have some statistics from the US. It's estimated that it also causes about over 500,000 neonatal deaths due to congenital malformation. And for those babies that survive, there's actually lifelong disability. Like I said, it can occur in any pregnant woman. WHO tells us that the majority of severe congenital anomalies actually occur in low and middle income countries. All right, and the possible causes or contributing factors to this could be infectious, could be low socioeconomic status, could be exposure to teratogens, particularly environmental teratogens, because I'm sure we all know that we don't have so many checks and balances in place that will help us to limit our exposure to these environmental teratogens. And of course, we should also remember that most of our pregnant women have unplanned pregnancies. May be wanted eventually when they get pregnant, but they actually didn't plan on having the pregnancy. And by the time they're coming in for their first prenatal visit, a lot of damage may already have occurred. So that may also contribute to the high incidence of congenital malformations reported in low and middle income countries like Nigeria. This slide is showing us the critical stages of human development. I'm sure we can remember these three main stages, week 1 to 2. This is said to be the period of all or none rule, in which case when the fetus is exposed to a teratogen, it's either the fetus gets destroyed completely and aborted, or it's not affected. If the fetus survives, then it survives without any long-term disability, because at this period, the cells are pluripotential. So if any of the cells are damaged, the other cells will make up for whatever damaged cells are there and move on. The next phase will be from the 3 weeks to 8 weeks, actually, 3 to about 8 weeks, in which case you can have affectation of CNS, the heart, and all that. That's the period of organogenesis. And then the fetal period is from the 9th week of gestation up to delivery. Yes, now this slide is also showing us the effect of timing of teratogen on prenatal development. As we'll see later, when a fetus is exposed to teratogens, the effect it has on the fetus depends on so many things. Genotype of the conceptors, genotype of the mother, the period of exposure to the teratogen, what organs were developing at the time that exposure occurred, what was the dose of the teratogenic agent. So from this slide, we can see that the central nervous system can actually be affected almost throughout gestation. Okay, almost throughout, that's this one here. Neural defects in the early part of gestation, and then later it can actually have mental retardation and other CNS anomalies developing right till term. All right, for some organs like the heart, the peak period of affectation is between the 3rd to about the 8th week of gestation. After that, the heart is completely formed, and then exposure to teratogenic influences are less likely to cause cardiac anomalies. The genitalia, as you can see here, is also affected throughout the fetal period, all right, because you have the external genitalia developing during that period. So that means that any exposure to any agent throughout that period, from around the 8th week right till delivery, can actually cause abnormalities in the external genitalia. Yes, now we look at the effect of teratogens of prenatal development. So this slide shows us that the peak period of teratogenic risk is actually around the 5th week of gestation. By the time the fetus is around 8 weeks, the risk decreases and continues to decrease up to term. And putting in mind, bearing in mind the fact that in our own environment, our women come late for antenatal care, usually around 20 weeks thereabouts, it shows that a lot of harm would have been done before they even come to us at all, and will not have been able to prevent any possible teratogenic effects on their fetuses. Even in developed countries, because even there, the first prenatal visit usually occurs around 8 weeks. By that time, the harm may have been done. So periods of affectation of the embryo, or the fetus, with 1 to 2, like I said earlier, all or none period. Exposure leads to either death of the embryo or no effect if the embryo survives. And then the period of organogenesis, with 3 to 8. That is when they are most sensitive to teratogens. And we saw earlier the periods of high susceptibility of these organs. And then from the 9th week to the 9th month is a less sensitive period. But during this period, you will still have structural malformations and also growth defects and functional abnormalities as well. This slide is also looking at critical periods of human development. You can say, like I said earlier, for the central nervous system from 3 to full term. For the eyes, is from the 4th week to full term. You can have eye affectation. Okay, the heart is usually fully developed by around the 9th week, so exposure after that is less likely to cause problems. Now we move on to the principles of teratology, which is the main thrust of this lecture. So principles of teratology is actually looking at how teratogens affect fetal development. And in 1977, Wilson actually described 6 main principles of teratology. The first principle says that susceptibility to teratogens depends on the genotype of the conceptors and how the conceptors actually interact with the environment. The second principle says it depends on the stage of exposure to the teratogen. And the third principle tells us that teratogenic agents act on specific tissues and cells in a specific manner to cause abnormal development of the embryo. The fourth principle states that the final manifestation of abnormal development can be a malformation in the fetus, can be abnormal growth in which you have growth restriction, can be a functional abnormality, and sometimes can cause growth intrauterine fetal demise. And then the fifth principle tells us that when there's an access to an adverse environmental agent, the effect it produces on the fetus actually depends on the nature of the agent itself, because some agents have low teratogenic potential, some agents have higher teratogenic potential. And then when this abnormal development occurs, the degree of abnormal development increases directly depending on the dosage increase of the teratogenic insult, from no effect to the lethal effect. That means that when you have a teratogenic agent, a small dose of the agent may actually cause no effect on the fetus, but you have a threshold level, in which case, when you reach that threshold, then effect on the fetus will be manifested. And when that threshold is really very high, then the chances of having an intrauterine fetal demise increases. So I'm just trying to give some examples of the teratogens that could use these principles to explain. All right, the first principle talks about susceptibility depending on the genotype of the conceptors and how it interacts with the environment. So, for example, the response of the fetus to alcohol differs. All right, so you have a woman that is alcoholic, and some of them will have the full spectrum of the fetal alcohol syndrome, while some of them may have only some of the spectrum, and some will actually have no effect at all, because possibly the genetic makeup of the fetus is able to repair any damages caused during fetal development by the alcohol. The same thing goes for thalidomide and phenytoin. For thalidomide, for example, even when the catastrophe occurred, it wasn't all women that were exposed to thalidomide that had fetuses that had abnormalities. Some fetuses had major limb defects. Some of them had only some of the features of thalidomide toxicity. Principle two, talking about susceptibility varying with the age or the stage at which the exposure occurs, still takes us back to the all or none rule in the first 2 weeks of development, and then the highest risk during organogenesis, and then lesser risk during the period of fetal growth and maturation, in which case most of the teratogens will actually cause problems of growth restriction or sometimes functional problems. Principle 3 tells us that there is abnormal development, and this can be through gene mutation, in which case the genetic constitution of the fetus itself is, there's a permanent change in the genetic constitution of the fetus. It can occur through vascular disruption, in which case you have affectation of the vessels, arteries, the veins and capillaries supplying blood, and that will actually also affect the growth of the organism. It can cause endocrine disruption. This is particularly common among hormonal substances like the diethylstilbestrol or use of combined oral contraceptive pills in the first trimester of pregnancy. It can cause inhibition of enzymes such that necessary proteins for the body to function are not produced, and that can also lead to functional defects in the baby. Yes, principle 4 tells us that manifestation of the abnormal development depends on the time the baby was exposed, as well as the amount of teratogen. So sometimes, for example, when you have exposure to some teratogens during the early part of organogenesis period, the central nervous system, the limbs and the eyes are more likely to be affected. And then when you have it occurring later during organogenesis, you can have ear malformations, affectation of the genitalia, teeth, and the palate. Like I said earlier, for the fetal period, it mostly causes functional defects, growth abnormalities as well. Principle 5, talking about access to the adverse environment, depending on the nature of the agent. It's just telling us that the nature of the agent, how did the agent get to the fetus itself? What truth did it go through? What is the placental clearance of the agent? What is the degree of maternal exposure? What is the rate of systemic absorption of the agent? So all this depends on the fetal genotype as well as the maternal genotype. For example, if the maternal genotype may be able to clear or metabolize a high amount of a teratogenic agent, whereas some mothers, depending on their genotype, may not be able to clear it properly. So if they are not able to clear it, that it presents a higher load to the placenta, and that will be transferred to the fetus, causing abnormalities in the fetus. So in a nutshell, we can say that teratogenesis is actually a multifactorial process because you have a complex interaction between nature now being the intrinsic genotypic makeup of the fetus and the mother, and then nurture being the environment the fetus is exposed to. The environment both within the mother and external environment acting through the mother. So this takes us to this slide that shows us how teratogens can actually influence prenatal development. Okay, it shows that the impact of teratogen depends on the organism genotype. We said that earlier, both for the fetal genotype and the maternal genotype. And then the impact changes over the course of development, depending on the period of time the baby was exposed, as well as the dose of the teratogen. It's always important to remember this last point, that damage is not always evident at birth. Sometimes damage can be picked up during antenatal period. Sometimes it's picked up in early neonatal period. Sometimes it's not picked up until even later on in adulthood before these abnormal developments are picked up. This is just to remind us about the thalidomide disaster, which occurred in the early 1960s. When the drug came, it was like a magic drug because it helped to control nausea among pregnant women. So it took several years after the drug had been used before it was noticed from epidemiological studies that women who had been exposed to these drugs had a higher chance of having fetuses that had abnormalities, and most peculiar abnormalities that occurred in thalidomide exposure were the limb defects, and then it also caused other abnormalities like cardiac anomalies, renal and GI anomalies. But the anomalies it causes also depends on the dose that was given and the duration of exposure to the thalidomide. Before we can say that an agent is teratogenic or has a teratogenic potential, there are certain criteria that needs to be established. All right. First of all, it must be proven that exposure to the agent during the critical periods of prenatal development actually occurred. That means that you need to prove that that the pregnant woman was actually exposed to the agent while she was within the period of critical embryonic development, usually the 3rd to the 8th week of gestation. And then you also need consistent findings from 2 or more high-quality epidemiological studies. Like we all know, it's not ethical to carry out drug tests among pregnant women. So most of the time, teratogens are discovered from case reports or from epidemiological studies, in which case, after a group of women have been exposed to a particular substance, you can have case reports coming up showing that this woman had this substance and this malformation was noticed in the babies. It's also important to carefully delineate the clinical cases. Another criteria to establish human teratogenicity is presence of teratogenicity in that agent when tested on experimental animals. But when we're looking at that, we should also remember that there are some agents that have actually been found to be teratogenic in animals and not in humans, and vice versa. For instance, aspirin is actually teratogenic among rats, but is not teratogenic to humans. Ideally, the association of the agent to the malformation should actually make biological sense, and there should be experimental proof that the agent was actually acting alone by itself in an unaltered state. So it's said that the first 4 criteria are quite essential, saying that an agent is teratogenic, whereas the 5th, 6th, and 7th criteria, though important, are not as essential as the first 4 criteria. Classification of teratogens. This can be classified into different groups. We have the drugs, both medicinal drugs and recreative drugs, maternal conditions like pre-gestational diabetes mellitus, deficiency states like folic acid deficiency, environmental chemicals like lead exposure, mercury exposure. We also have infectious agents, rubella, cytomegalovirus, Zika. Okay, we can have radiation, and some people talk about possibly paternal factors causing increased occurrence of teratogenic insult on the baby. So drugs can be medicinal or recreational. Okay, recreational drugs like cocaine, like heroin, like smoking and alcohol, all these have an effect on the fetus. Cigarette smoking, for example, has been found to be associated with cardiac defects and gastrointestinal defects, as well as musculoskeletal and limb defects. Whereas I'm sure we all remember the fetal alcohol syndrome that is associated with maternal alcohol use during pregnancy. And there's a common saying that a pregnant woman does not take alcohol alone, all right? This is just trying to remind the pregnant women that when they're taking alcohol during pregnancy, they're actually not taking it alone, they're also feeding their baby on alcohol, and there's a potential effect of causing an anomaly on the baby. Other common drugs, pharmacological drugs that could cause malformations include the anticonvulsants, progestins, combined oral contraceptive pills, warfarin, ACE inhibitors, and of course we have the antibiotics like streptomycin and tetracycline. Maternal conditions that could cause teratogenic insults on the baby include pre-gestational diabetes mellitus. And this is very, very important. In those days, previously, before the discovery of insulin, women that had pre-gestational diabetes mellitus, they didn't even survive to puberty, so they didn't even get pregnant. So I can even say that perhaps there wasn't any pre-gestational diabetes mellitus. Most diabetic women were dying before they could have children. But with the advent of insulin, of course, we had women living longer, getting to puberty, getting into the reproductive age, and then also having children. So it's important to actually control blood sugar properly before embarking on a pregnancy for one that is known to have pre-gestational diabetes mellitus. The effect of gestational diabetes mellitus is not a teratogenic effect per se, because it develops later in pregnancy. That is more likely to cause growth abnormalities in the baby and not congenital malformations like the pre-gestational diabetes will cause. And common anomalies found in diabetic babies include cardiovascular defects, sacral defects, and then we've had the diabetic embryopathy actually described. Another maternal condition that will cause anomaly is phenylketonuria. This is one of the only known human metabolic disorder that is teratogenic, because it's almost like an absolute thing. Once a woman has phenylketonuria and she's not well controlled, then the chances are very high that the babies she has are going to develop abnormal features, including microcephaly, heart defects, and abnormal facial features. Maternal conditions can also include deficiency states, like folic acid deficiency, causing increased occurrences of neural-2 defects, and also iodine deficiency, causing cretinism in the baby, and also congenital goiter in the baby. Environmental chemicals like lead can cause structural and functional defects in the baby, and mercury can also cause structural and functional defects in the baby. This is important, particularly for women that work in industries. And it's actually also been said that paternal exposure may also be important, because it's been discovered that some men that have been exposed to these chemicals in industries actually have an increased risk of having babies that have congenital malformation. We'll move on to infectious agents. There are many viruses that have a potentially teratogenic effects on the fetuses, including the rubella virus, first described in 1943, which can cause cataract, heart defects, deafness in the baby. We have cytomegalovirus, varicella zoster, Zika virus, and even HIV. And well, I know it's not yet been quite documented about coronavirus. Who knows, from epidemiological studies, sometimes we could actually discover that it may also have potential been proven to be transmitted vertically. Radiation. Of course, the higher the dose of radiation that the woman is exposed to, the higher the risk of embryonic injury, causing congenital malformations or even cell death. So it's very important to ensure that pregnant women are protected from radiation, especially high doses of radiation. And if for any reason you have to do an X-ray, for instance, on a pregnant woman, then it's better to offer an abdominal shield to reduce the risk of exposure of the fetus. Now, this is trying to show the mechanism by which ionizing radiation causes birth defects or even other drugs. So sometimes you have a drug exposure, and the drug may actually be activated in the placenta, producing reactive oxygen species, which acts like a pro-teratogen. If the mother's genotype is able to clear this reactive oxygen species, for example, she has some DNA repair genes that repairs damages, or sorry, she has some genes that helps to clear that helps to produce enzymes that clears it quickly, then the load to the baby is going to be reduced, and the chances that the baby will have a birth defect reduced. The baby's genotype has some repair genes that are able to repair the damage to the cells. Then you have the cells being repaired, and then birth defects are averted. But if these reactive oxygen species are not stopped, then it progresses on to act as a teratogen, causing defects in the baby. Paternally mediated teratogenesis, like we said earlier, have been reported in animal studies and also some epidemiological studies. And the main mechanisms are said to be exposure of the man's semen to the drugs. Okay, and sometimes you can have, sorry about that. Sometimes you can also have genetic mutation in the father as a result of exposure to that drug, such that the father's genes in the X and Y chromosome are in the X and Y chromosome become abnormal, and that is transmitted on to the offspring. And of course, sometimes it can have the epigenetic effect because of methylation of the DNA within the father's semen. All this makes it important for us to also involve men when we're talking about teratogenicity, so that they realize that when we talk about healthy behavior, it doesn't stop just at the woman's door, but the man also needs to be sure that he also protects his unborn babies. I'm sure we're all familiar with the US FDA pregnancy category definitions. This was made by the Food and Drug Administration Agency in the US to help us to serve as a guide to determining whether or not we can safely use a drug for a pregnant woman. Okay, we have category A, in which control studies on pregnant women fail to demonstrate a fetal risk, and the risk of harm appears very, very remote. And examples are folic acid and aluminum sulfate. And then you have category B drugs, in which case animal studies don't show increased risk to the fetus, but there are actually no control studies in women. And examples of such drugs are metformin and amoxicillin. Category C, in category C, animal studies have shown that these drugs actually have a teratogenic effect, but there are no control studies in women because of ethical concerns. So you only give these drugs to a pregnant woman if the benefits of giving the drug actually outweighs the risk. Okay, that means that the drugs have actually not been shown to be harmful to fetuses. Sorry, that was for category B. Category C, drugs are not harmful to the fetuses. So you only give it to women if the benefit of giving the drugs actually outweighs the risk. We also have category D drugs, in which you have evidence of fetal risk. But sometimes, if you feel the benefit outweighs the risk, you may make the drug available to a pregnant woman. For example, rarely use of lisinopril during pregnancy. But even if you're going to use these drugs, you want to avoid the peak period of organogenesis to reduce the effects that these drugs have on the developing fetus. The last category is category X, in which studies in animals or humans have demonstrated that there is actually abnormality based on drug exposure. And that means that the risk of using that drug outweighs any possible benefit. So this drug should not be used at all for any reason during pregnancy. For category A drug, though we give example of folic acid and aluminum sulfate, you can't categorically say that any drug actually falls into this category. It's just because nothing has been found to cause, no abnormality has been found in women exposed to folic acid, and it's also been found that folic acid deficiency actually causes fetal anomaly. That's why this drug is within the category A drug. Now, this is the beginning fetal ultrasound course, so we thought we should talk a little bit about the role of ultrasound and the limitations in teratology. So ultrasound, of course, is important for making your diagnosis of fetal defects, identifying fetal defects, both major defects and minor defects. It's also important in monitoring the fetus. Monitoring will include monitoring the defect itself, because some defects are found early on in gestation. After some time, you repeat the ultrasound and the defect appears to have resolved or gotten worse. Monitoring will also help you to monitor the growth of fetuses, because we said some of these effects can actually have an effect on growth, causing growth restriction. So sometimes you need to monitor to see how the baby is growing. And of course, the monitoring can also help you to determine the optimal time for delivery if you think that the fetus is compromised. Ultrasound is also very important in performing invasive procedures like amniocentesis, your perineal sampling, and all that, and also for in utero therapy. But despite all these advantages, antenatal ultrasound actually has some limitations in teratology, all right? Sometimes the views you get on ultrasound can be limited by the skill of the person doing this. In this environment, once you have the money to buy an ultrasound machine, you can set up a shop somewhere and be doing your scans, all right? So we may not be able to rely completely on all the scan reports that we get, because if the person doing the scan doesn't have the requisite skills, then that person is not likely to pick up these abnormalities. And there are some abnormalities that are even much more technical and more difficult to pick up, particularly cardiac anomalies, than other anomalies like anencephaly. Views on ultrasound can also be limited by the equipment that you're using to do the ultrasound. All right, so it's just like using a technophone to take a picture and you're comparing that to the output you get from a Samsung or an iPhone. It's likely to be different. The maternal habitus can also limit the view that you get, particularly in obese women. This in obese women, you don't get very good views. So all this may limit the diagnosis of fetal anomalies on ultrasound. So it's important that before we diagnose anomalies, we first of all get properly trained to make sure we are able to pick up as much as possible anomaly. But first we need to recognize normality so that even if you cannot pick up an abnormality clearly, as long as you know that the ultrasound that you have done doesn't look too normal, then you can always refer to somebody that has a better skill to make the diagnosis and manage the woman appropriately. And when you're doing your detailed scan, of course, as well, if one is not able to see any of the fetal structure, maybe due to the fetal position or the maternal habitus, it's important to document properly and also counsel the woman and possibly book another appointment for the scan to be repeated to see whether you could get a better view, or possibly also refer the woman to somebody else to repeat the scan for her. Anomalies picked up on ultrasound also depends on the gestational age. Most anomalies are picked up around the mid-trimester scan, around 20 weeks, but some anomalies can actually be identified even from the first trimester of pregnancy, particularly these central nervous system anomalies. And even in skilled hands, cardiac anomalies can actually also be picked up in the first trimester of pregnancy. But it's important to also counsel our pregnant women so they know that not all anomalies are detected by ultrasound. All right? Because it's possible for you to do an ultrasound despite all your skills and miss out some anomalies. Of course, there are some that are unforgivable, like the anencephaly. But cardiac defects, for example, even in the best of hands, pick-up rate is quite small for cardiac defects. So one can actually be forgiven for some defects, but it's important to undergo proper training to improve one's pick-up rate for these anomalies. Another limitation of the antenatal ultrasound is that when you pick up a structural anomaly, that doesn't necessarily mean that there's going to be a good function or bad function for the fetus or the baby when the baby is born. So severe structural anomaly does not necessarily translate to severe abnormality in function. And even if the structural anomaly appears to be mild, that does not mean that functionality of that organ will be completely normal when the baby is born. So it's important to counsel these women adequately so they know what to expect. Predicting teratogens. There's a limitation to predicting teratogens because most of the teratogens that we have are based on animal studies. And like I said earlier, the metabolism in the animals that are usually used, rats, pigs, and all that, is not exactly the same thing as that in humans. Some teratogens cause abnormality in animals without causing it in humans, and vice versa. So there's species discordance, and that can actually limit the predictability of teratogens based on animal studies. Also, like I said earlier, it's unethical to carry out studies on pregnant women. So most of the information that we have are from epidemiological and epidemiological studies and case reports. Now, when should we consider teratogenesis? Okay, this is something that should be considered in all women in the reproductive age group, because like I've said, all women that will get pregnant will actually have a baby that has a congenital malformation. So we should consider it before pregnancy. And ideally, pregnancy should be planned such that the woman optimizes herself properly before she embarks on the pregnancy, thereby reducing the risk of exposing her fetus inadvertently to teratogens. Before pregnancy, we also need to consider safety of drugs, especially for women that have chronic disorders like epilepsy, diabetes mellitus, hypertension, and all that. So we should consciously ask women before prescribing drugs, as long as these women are within the reproductive age group, what their pregnancy intentions are, so that we don't inadvertently contribute to the development of defects among these women. During pregnancy, we should also consider safety of prescribed drugs. It's usually said that you offer the minimum number and the lowest dose that is effective to manage the condition that you're trying to manage, just to reduce the risk of exposing the baby to teratogenic influences. And of course, when we're doing a detailed ultrasound, we should counsel the woman before the ultrasound, during the ultrasound, and also after, explaining whatever findings that are obtained on the ultrasound. And if we have the facility, we can actually offer serum tests and a prenatal diagnosis. We need to consider teratogenesis even after the pregnancy is ended. First, by completely examining the baby that is born to make sure that no anomaly is missed out. All right. It's also important to look at the possible etiology of the anomaly and possibly trace back so that you can counsel the woman adequately and prevent a recurrence of that anomaly in future offspring. And then, of course, we need to consider postnatal management, counseling for the parent, and you may also need to involve other disciplines like pediatric surgeons, the counselors, genetic counselors, and all that in managing these babies that have been exposed to teratogens. Now, before pregnancy, of course, we talk about healthy lifestyle, avoid smoking, avoid alcohol intake, no amount of drug is safe for the baby, control maternal diseases, control the drugs to the barest minimum and the fewest number of drugs that can control the mother's medical condition like epilepsy. Offer immunization like the rubella vaccine to women in the reproductive age group so that they don't come down with rubella during pregnancy. And of course, we talk about folic acid supplementation for all pregnant women, which has been achieved in some countries by ensuring that their flour is fortified with folic acid, just to ensure that pregnant women have the minimum amount of folic acid that will help them to prevent neural tube defects. And of course, you try as much as possible to avoid exposure to teratogenic influences during the preconception period. During pregnancy, you also consider use of the drugs, offer detailed ultrasound, and then invite a multidisciplinary team in case any anomaly is picked up. And like I said earlier, if you pick up one anomaly, the chance of having more are increased. So you need to take a second look, examine the fetus from the head to the toe to pick up any anomaly. And it's also during pregnancy that you also consider the options for the woman. For example, you can cancel on termination of pregnancy if the circumstances permit. And also plan postnatal management. These women need to deliver in a specialist facility so that you have the pediatric surgeon in attendance. Is the baby likely to need NICU admission after delivery? So all this should be discussed during pregnancy with the mother. And also the postnatal treatment that you need to offer to the woman should also start the discussion right from the antenatal period so that necessary team will be put together before the baby is born. You also need to discuss care of the affected child with the woman so that she realizes what she needs to do to take care of the affected child in terms of whether the baby is going to need surgery, what is the quality of life that she needs to expect for the baby, and all that. Now, I have some recommendations to help us to reduce exposure to teratogens among our pregnant women. First of which is birth defect surveillance. Unfortunately, we don't have a birth defect surveillance system within the country. A lot of developed countries actually have their own birth defect surveillance. And this is how they pick up teratogens and other anomalies as well. So it's very important for us to think about setting up a birth defect surveillance in the country to help us monitor the occurrence of anomalies among our pregnant women. Education is very important, education of stakeholders. And who are the stakeholders? The women and their husbands, of course, healthcare workers, the government and other are all stakeholders in preventing or reducing congenital malformations from exposure to teratogens. We need to encourage women to have planned pregnancies because like we said earlier, a lot of anomalies would have occurred even before the woman has her first prenatal visit, all right? So, but if she actually planned the pregnancy, she would have optimized her own health, she would have commenced folic acid preconception and all that, all in a bid to reducing the possibility of occurrence of fetal anomaly. We should also consider dietary supplementation. For example, we think about fortifying our salt. It's already fortified with iodine, but is it possible to also fortify with folic acid and also fortify flour with folic acid, also to ensure that all women in the reproductive age group have a minimum level of folic acid, thereby reducing the occurrence of neural tube defects. It's important to train health workers on antenatal detection of fetal anomalies, and ultrasound comes in very, very useful in this guys. And of course, also to perform a complete physical examination of all newborns so that we don't have anomalies being picked up after the mother has gone home with the baby or even later in life. So we can see that the best way to reduce teratogenic influences on the developing fetus is to reduce the exposure of the mother as much as possible. But like we said before, prevention can be a bit complicated because our pregnancies are not planned and women are exposed to teratogens in the environment and don't present until after the period of organogenesis. So take-home message, we should remember that all women in the reproductive age group are potentially at risk. Every chemical substance is a potential teratogen. The effect of teratogens depends on the dose of the teratogen, the duration of exposure, the timing of exposure, as well as the genotype of the fetus and that of the mother. Even though we say that the period of organogenesis is the most critical period for development, there is no stage of development that is completely safe, and you could have teratogenesis occurring at any of the stages of development. Preconception care and multidisciplinary management is very, very important in managing fetuses that have been exposed to teratogenic influences. So as a recap, we've talked about teratogenesis, birth defects, and significance. Talked about the 6 principles of teratogenesis, prenatal development, tried to classify teratogens, and also looked at some criteria to determine teratogenicity of substances. We also looked at the FDA classification of drug teratogenicity, the role of ultrasound, and also how to prevent fetal malformations from exposure to teratogens. Thank you for listening. Any questions?
Raji, I want to say a very big thank you for taking up this extremely difficult topic. It's a topic that most persons would not want to take up.